this lecture, I'll be teaching on primary amenorrhea. I am Professor Olushola Benjamin Fashuba of the Department of Obstetrics and Gynecology, Obafemi Awolowo University, Ile-Ife. At the end of this lecture, you should be able to define and classify the types of amenorrhea and know the basic factors involved in the onset and continuation of normal menstruation. 2. You must be able to describe the various etiology of primary amenorrhea. And 3. You must be able to recognize and evaluate cases of primary amenorrhea. And lastly, appreciate the role of counseling and some specific treatment in primary amenorrhea. Amenorrhea is just the absence of menstruation. Amenorrhea is just the absence of menstruation. It can be physiological or pathological. It can be physiological or pathological. Physiological amenorrhea is seen before puberty or after menopause, during pregnancy and during lactation. Physiological amenorrhea is seen before puberty or after menopause, during pregnancy and lactation. Amenorrhea occurring outside these 4 periods is pathological. Amenorrhea occurring outside this period is pathological. Again, amenorrhea can be defined as primary or secondary. Can be defined as primary or secondary. Primary amenorrhea, when a woman has never had spontaneous menstruation. Primary amenorrhea, when a woman has never had spontaneous menstruation. And this is the topic for today. Secondary amenorrhea has had one or more spontaneous menses before menstruation ceases. That is, a woman that has been menstruating previously, then menses suddenly ceases. So these type of patients are said to have secondary amenorrhea. But in primary amenorrhea, a woman has never had a spontaneous menstruation. About primary amenorrhea, the first menstrual period is known as menarche. The first menstrual period is known as menarche, and the age at which menarche occurs varies from one society to the other. And this age seems to be decreasing gradually all over the world. In Nigeria, the mean age of menarche is about 13 to 14 years. About 13 to 14 years. But we have isolated cases of some ladies having their menarche at 11, 12 years. But the mean age is 13 to 14 years in Nigeria. Preceding menarche are the development of secondary sexual characteristics, such as the growth spur, the female hair distribution, the axillary, and then the pubic hair development. And breast development and the menarche are external manifestations of development of sexual maturity. The first secondary sexual characteristics are emergence of growth spots, female hair distribution in both the axillary area and the pubic, followed by breast development, and menarche is the final stage of puberty. The continuation of normal menstruation depends heavily on the following basic factors: normal female chromosome pattern, 46XS, coordinated hypothalamic pituitary ovarian axis, coordinated hypothalamic pituitary ovarian axis, the anatomical presence and patency of the outflow tract, responsive endometrium, and active support of thyroid and adrenal gland. Any aberration in any of the above process may result in failure of sexual maturation or absence of menarche. When a lady has a normal chromosomal pattern and a well-coordinated hypothalamic pituitary ovarian axis, and the presence of and the patency of the outflow tract and the responsive endometrium, this lady is bound to have a continuation of pregnancy. What do we talk about coordinated hypothalamic pituitary ovarian axis? In this respect, the hypothalamus secretes gonadotrophin-releasing hormone factors. The hypothalamus secretes gonadotrophin-releasing hormone factors, and this acts on the anterior pituitary to release the gonadotropins. The gonadotropins, the follicle-stimulating hormone, and then the luteinizing hormone. Both follicular stimulating and luteinizing hormone, they act on the ovary. The FSH, which is the follicular stimulating hormone, acts on the ovary to begin to secrete, to produce estradiol, and the LH produces the progesterone. The estradiol will stimulate the endometrium to grow, and the balanced action of the estrogen with progesterone will cause menstruation to occur. And this is what we meant by coordinated hypothalamic pituitary ovarian axis. And in the presence of outflow tract, menstruation will begin. The WHO has recognized that any woman fulfilling the following criteria should be evaluated as having the clinical problem of primary amenorrhea. The following problems: 2. 1. No menstrual period by age of 14 years in the absence of growth or development of secondary sexual characteristics. If there is no menstrual period by the age of 14 years and there is no external manifestation of development of secondary sexual characteristics, this type of a woman can be classified to have a primary amenorrhea. Or no menstrual period by the age of 16 years, regardless of the presence of normal growth and development with secondary sexual characteristics. Because if you look at the age at which our women attain menarche, 16 years and above should be more than the two standard deviation from the mean. So if a woman by the age of 16 years has not achieved the first menarche at 16, even though there is a normal growth and development of sexual characteristics, this woman will be evaluated to have a primary amenorrhea. Classification of etiology of primary amenorrhea. So we are talking about etiology of primary amenorrhea. And in classical textbooks, they have been classified to be 1. Hypergonadotropic hypogonadism, 2. as hypogonadotropic hypogonadism, and 3. eugonada. That is, those of them that have normal gonads, but there are some pathological problems. And lastly, those people that have virilism, they have virility conditions, producing either voice changes or excessive hair growth. That's in classical textbooks, and we will explain this. So the first I said is hypergonadotropic hypogonadism, and there are two variants of this. Those that have abnormal chromosome or chromosomally incompetent ovarian failure. Chromosomally incompetent. And we said the normal chromosome is 46XX. But in those that have hypergonadotropic hypogonadism, the chromosome of the ovaries is incompetent. And we can see this in the classical case of Turner syndrome. Turner syndrome, or all other X deletion syndrome, and 45X, 46XY, that we call classical mosaic Turners. Mosaic Turners. We're going to discuss some of this later on in the lecture. The second variety is the chromosomally competent ovarian failure. In this case, these women, they have 46XX. They have normal chromosome. They have normal chromosome, but the ovaries cannot respond. And classical examples here are the true agenesis. The true agenesis. Then we can have premature ovarian failure. Premature ovarian failure resulting from irradiation before puberty, or chemotherapy before puberty, or autoimmune response, like in patients that had Burkitt's lymphoma in early life. By the age of 3, 4 years, 5, you may have Burkitt's lymphoma or other lymphomas that have been subjected to irradiation or chemotherapy. This type of patients may never achieve a MENAC, and they could present as primary amenorrhea. And lastly, galactosemia. This is an inherited enzyme deficiency. Patients with galactosemia, they may present with primary amenorrhea. The second category of patients with primary amenorrhea in terms of classification are those people that have hypogonadotropic hypogonadism. Unlike in the first case, where there is hypergonadotropic hypogonadism, those people with hypergonadotropic hypogonadism, they have high FSH, high follicular stimulating hormone, and a high luteinizing hormone. That's why they are hypergonadotropic hypogonadism. But in the case of hypogonadotropic hypogonadism, they have low follicle stimulating hormone and low luteinizing hormone. Two types of these hypogonadotropic hypogonadism can be seen. We have the reversible and then the irreversible hypogonadotropic hypogonadism. The reversible hypogonadotropic hypogonadism occur in patients with physiological delay. They are normal, they have normal gonads, normal chromosomal status, but there is a delay in achieving the secondary sexual characteristics that will manifest in the first menstrual period. Physiological delay. In this type of physiological delay, when you see them, they may be of a either short statured or tall, but they will have a minute external manifestation of the secondary sexual growth development. And there are some groups of women who have weight loss, chronic weight loss, or anorexia, or heavy exercises. In this type of patients with weight loss, great weight loss, are the people that have bodystic activities, women that participate in very strenuous exercises, those women that get involved in sports, they may have chronic weight loss, in which case there is a maximum weight loss that is essential before menarche occurs. So these women may not attain that potential. And lastly, under reversible hypogonadism, we call primary hypothyroidism. Primary hypothyroidism. In these patients, the thyroxine hormones are deficient and they are not enough to support the process of the normal menstruation. The irreversible hypoglycemia could be congenital and it could be acquired. The irreversible could be congenital or acquired. And in most cases of women that are short and that have sexual infertilism and lack of secondary sexual characteristics, they belong to the group called congenital irreversible hypogonadotropic hypogonadism. For instance, the patients with Lorraine-Levy syndrome, the Lawrence-Moonbed syndrome, they have congenital anomaly due to some what we call pan-hypopituitarism as a result of congenital central nervous system defects. These patients, they have low follicular stimulating hormone and they have low luteinizing hormone. Even the human growth hormone is deficient. The human growth hormone is deficient, it's low as a result of congenital central nervous systems. You know, when the hypothalamus, there is nothing in the hypothalamus, the pituitary is empty, and they just come and they develop persistent juvenile status. And this group of congenital anomaly that we see could be found in Lorraine-Levy syndrome or Lawrence-Moonbed syndrome. The acquired variety of this non-reversible hypogonadotropic hypogonadism can occur in hyperprolactinoma. Hyperprolactinoma, in which there is a growth of the prolactin cells. They are secreting a lot of prolactin into the circulation. And we can have this in pituitary adenoma. Pituitary adenoma with prolactinoma or prolactinoma plus acromegaly or Cushing syndrome, or patients producing gonadotropins or innards. The cage that houses the pituitary gland may be empty. We call it an empty cellar syndrome. The cage where the pituitary gland sits may be empty cellar. Then chronopharyngioma, tumors of that area can give rise to irreversible hypogonadotropic hypogonadism. And occasionally, trauma, including surgery, trauma. When a woman falls and hits the head, it could damage the cranium and probably affect the hypothalamus. And effect of surgery as well could give rise to the same nature. The third category is the eugonada. They have normal gonads. And the typical example that we have is anatomical. There is a problem with the anatomy. In this case, you may have a defective embryological development. Defective embryological development, right from uterus, from in utero. In which case, the heterovaginal axis may not be developed, that we call heterovaginal agenesis. And the uterus is not developed, or the vagina is not developed. These patients can have primary amenorrhea. And we talk of a complete uterine agenesis. If the uterus is not developed at all, we may present with primary amenorrhea. Sometimes uterus may be present and the vagina is absent. When the vagina is absent and the uterus is present, it's quite possible to present with primary amenorrhea, and you can have dampening of blood, like what called cryptomenorrhea, or sometimes hydrocorpus to cryptomenorrhea to hematosappins, and then to blood accumulating in the abdomen. Another anatomical problem that we see more often is the imperforate hymen, when the hymen is not perforated as it used to be, or there's a transverse septum just above the hymen. This may also lead to dampening of the menstrual blood in the vagina, or that gets to the uterus, to the fallopian tubes, and then to the abdomen. And all these things could present with primary amenorrhea. This anatomical disturbance is one of the commonest reasons of primary amenorrhea in our environment. It's one of the reasons for primary amenorrhea in our environment. The polycystic ovaries is the second type of eugoionate that you see. This polycystic ovary will arise before puberty or in the post-pubertal area, and this will cause a high level of aldosteronism. And these patients, the ovaries will be enlarged, and they may present with amenorrhea, infertility, and menstruation disorders. But the majority of these polycystic ovaries present in adults when they present with infertility clinic. And lastly, Noonan's syndrome is another factor that could lead to primary infertility. And in our classification, the last is the virility conditions that could be due to adrenal hyperplasia, congenital adrenal hyperplasia. Usually, if not recognized in the newborn, it may persist to adult and come with post-pubertal adrenal hyperplasia. And this adrenal hyperplasia should be distinguished from adrenal tumors. And the difference between adrenal hyperplasia and then the tumor of the adrenal ovary is that beta-metasone suppression will cause a suppression of the steroids that are produced from hyperplasia of the adrenal. Unlike the tumors of the adrenal, because they are so high, beta-metasone will not be able to suppress this. And they can have absent anti-Mullerian factor that we see in testicular feminizing syndrome. In testicular feminizing syndrome, we see absent anti-Mullerian factor, in which case the testis produces testosterone, but the end organ receptors cannot utilize this to produce the hydrotestosterone that is useful to the body. Then we have true hermaphrodites, where the one section of the gonad is ovary and the other part of the gonad is testis. So this can give rise to virility conditions. Yes, the take-home from the above classification that we have just explained is that the etiology of primary amenorrhea could be summarized as follows. 1. Delayed puberty, chromosomal abnormality, for instance, Turner syndrome, end organ resistance, For example, androgen insensitivity typified by testicular feminization syndrome. 4. The outflow tract abnormalities, e.g. vaginal atresia or uterovaginal atresia, that is probably called Ulcer-Costa-Meyer-Rotanstansky syndrome. No, that's a good example that is so commonly known by many of our medical students and postgraduate students. Hypothalamic pituitary abnormalities, like we have said, the acquired, the irreversible. And then finally, the end organ disorders, for instance, adrenal hyperplasia. So these 6 categories summarizes the entire table as the etiology of primary amenorrhea. One can have delayed puberty, we have chromosomal abnormalities spreading from the chromosomes, and problems of the end organs resistance, the problems with the outflow tract abnormalities, and then hypothalamic pituitary ovarian acids and end organ disorders. Then let us see how can we recognize these patients when they present to us in the clinical setting. How? The majority of individuals with primary amenorrhea, it is possible to arrive at a fairly firm provisional diagnosis from the history and the results of physical examination. It's possible to arrive at a fairly firm provisional diagnosis from the history and the results of physical examination. And how do you get done? How do you get this done? Usually, the patients will come with the history of not having menstrual period since birth. That's the typical history. The typical history that she has never had a menstrual period from birth. Yes. So, and most of the time, these patients come with their mother or a senior sister for this. Usually, that's the typical presentation. Accompanied by the mother, and the woman says, I have never seen my period since I was born. So, in this type of setting, it's normal to ask from the mother if she had taken some drugs while she was pregnant. For instance, thalidomide or some other steroids during pregnancy. It's also important to find out if this lady suffered from any illness while she was young, maybe before 5, 7, 10, that she had chemotherapy or radiation therapy or some other forms of illnesses like autoimmune problems that will show maybe she is having problems that has to do with hypogonadotrophic hypogonadism. And again, you might want to find out if this woman, if they have the abnormalities of the organs of smell, or if this lady has been feeling concerned with hair growth elsewhere in the body, or the voice has been changing from that, or is passing like a male voice. This might just give you an idea of what she's going through. And it's also possible for you to ask if this woman has gone to meet a physician who has probably administered some drugs and she has a little blood or did not bleed. So this is very important. This history must not be forgotten. History of previous administration of steroids to induce menses. You must find out. History of previous radiation, history of drug injection also should be known. It is only in the minority there is a need to go beyond fairly simple outpatient investigations. Like I said, a firm provisional diagnosis can be made from the history and the results of physical examination. It's only in a very few minority that you need to embark on bigger outpatient investigations. In defining these patients, in recognizing these patients, the most important considerations are height. The height of the woman. Is this woman tall or is short? Then secondly, sexual infantilism. Sexual infantilism. That is juvenile persistent infantile structures. Persistent juvenile structures. The way she talks, the way she looks, like infants. Like infants. Sexual persistent sexual infantilism. And lastly, secondary sexual characteristics development. So you must look into these three. The combination of these three will help you to classify the type, a probable diagnosis. A probable diagnosis, the height of the woman, the sexual infantilism, and secondary sexual characteristics. Sexual characteristics, that I've said, growth factors, the growth, presence of pubic, axillary, the pubic and axillary hairs, breast development, and then lastly, menarche. So we must see the evidence of this must be present before we consider a firm diagnosis. Yes, let's look at this table. A girl of 15 or 16, who has no secondary sexual characteristics, obviously has not been exposed to any stimulation from gonadal hormones. A girl of 15 or 16 who has no secondary sexual characteristics, obviously has not been exposed to any stimulation from gonadal hormones. The gonadal hormones I talked about, estrogen and progesterone, from a properly coordinated hypothalamic pituitary ovarian must have that, because we expect the gonadotrophin releasing factors to produce the gonadotrophins, the LH and FSH, and this must be able to stimulate the ovaries to produce estrogen and progesterone. And it's the estrogen that will start development of the secondary sexual characteristics. So the first on the left is the idiopathic delay of sexual development. Idiopathic delay of sexual development. And that of the right, those with the idiopathic delay of sexual development. This group may not commence sexual maturation until the age of 15 or 16 and above. The people with the people with a girl of 15 or 16 who has no secondary sexual characteristics that has obviously has not been exposed to any stimulation from gonadal types, and they could be of two types: the idiopathic delay of sexual development, and this group, as I said, may not commence sexual maturation until 16 or above, 16 years and above. And they may need observation for about a year or more. For example, Froelich syndrome, young obese lady with delayed menstruation and puberty. Froelich, they are obese, they are young, but they also have delayed menstruation and puberty. These patients do not have detectable pathological lesion. They do not have detectable pathology. And in some of these patients, there could be a manifest, minute presence of secondary sexual characteristics. Very minute. It's possible that they have. So spontaneous remission will occur in the majority of them. Spontaneous remission will occur. Yes. And the other category is this pathological sexual infertilism, usually from hypothalamo-pituitary area or in the gonad. The extreme is the pathological sexual infertilism. Most of these patients here are short-statured. For example, Lauren-Levy syndrome or Lawrence-Moon-Beard syndrome. They result from congenital hypothalamo-pituitary disturbance. They result from congenital hypothalamo-pituitary disturbance. And the sexual infertility is so in this type of two cases, this example that I mentioned, the Laurent-Levy syndrome or the Lawrence-Moubert syndrome, the sexual infertility is recognized before the age of puberty. The sexual infertility is recognized before the age of puberty. For instance, the Laurent-Levy type dwarfism manifests by the third or fourth year with evidence of growth retardation, persistent juvenile fissures, hypogonadism, hypothyroidism, or hypoadrenocorticism. So, Laurent-Levy, short-statured, growth retardation becomes manifest by the age of third or fourth year with evidence of growth retardation, persistent juvenile fissures, hypogonadism, hypothyroidism, and hypoadrenocorticism. The Laurent-Moubert syndrome, in addition to these persistent juvenile fissures and all this hypogonadism, hypothyroidism, they have retinitis pigmentosa. They have high defects. They tend to have polydactylism, in which case their fingers are more than 5. They have polydactylism or syndactylism and mental retardation. Syndactylity means there is fusion of the fingers. There will be fusion of the fingers in both hands, both areas. So when you see that evidence of high disorder, retinitis pigmentosa, polydactylism or syndactylism, and evidence of mental retardation in a short-statured patient, the diagnosis can just be obvious. Lawrence-Moubert syndrome. Lawrence-Moubert syndrome. When you see a child of about 3 or 4 years with evidence of mental retardation and hypogonadism, so the diagnosis of Laurent-Levy type syndrome can be made. Other girls with sexual infertility plus short height may have chromosomal abnormalities leading to gonadal dysgenesis. Yes, we've said that earlier on. Short-statured women, evidence may have chromosomal abnormalities, either competent or incompetent. But most ladies that are short-statured that have evidence of chromosomal abnormalities may belong to the group called Turner's syndrome or Turner's mosaic. Short-statured, evidence of chromosomal abnormalities, they all may likely be in the category of hypergonadotropic hypogonadism, and they are more likely to be Turner's syndrome or Turner mosaic. In addition to these people being short, these women being short, the Turner syndrome, the patient has a webbed neck. You can see them, the neck is webbed down. There's an increased carrying angle at the elbow. There is increased carrying angle at the elbow. And then there may be evidence of congenital cardiac lesion. And sometimes the ears may be lower than normal, the hair than normal. And they may have some abnormalities of the eyes as well. When you see all these typical features, short-statured woman, webbing of the neck, increased cardiac angle, lower ear sets, and evidence of congenital cardiac lesion, then the diagnosis, of course, is clear. Turner syndrome will be suspected. And what you need to confirm this is a karyotype, simple karyotype, in which case you will see 45 chromosomes, 44 autosomal chromosomes, and 1 single sex chromosome. Ideally, in a normal woman, there are 46 chromosomes, 44 autosomal chromosomes, and 2 sex chromosomes. So when you do a karyotype, either from the buccal mucosa or from the skin, then you will find a 45 exo. That 45 exo is typical Turner's. And sometimes there may be 2 lines of cells differentiation in the same patient, in which case a group will be 45 exo and the other group will be 46 XS or 46 XY. These are the group called mosaics. Because in mosaics, there are two different lines of cells. Two different lines of cells. So when you have mosaics, some of them may have uterus, maybe small uterus, and they may have menstruated. And some of these mosaics can even go back and get pregnant. Yes, we have talked about short patients with sexual infertility. Short patients with sexual infertility. And we have talked about Turner syndrome, we have talked about Lorentz-Levy syndrome, we have talked about Lawrence-Moonbeard syndrome. Short-statured sexual infertility and no secondary growth of sexual characteristics. For the tall patient with sexual infertility, they can be encountered. They can be encountered in the clinical setting. Tall patient with sexual infertility. And the typical example of this is the Kalman syndrome, or the patients with olfactogenital syndrome. That is, they have disorder of smell. The diagnosis in this type of patients lies between the true gonadal agenesis and hypogonadotropic hypogonadism. The diagnosis lies between the true gonadal agenesis and hypogonadotropic hypogonadism. The patients with true gonadal we have defined them in our introduction section as people that have been exposed who have normal gonads. They have normal gonads with 46 XS, and some of them may present with galactosemia, or patients who have been exposed as a result of some diseases in this early childhood, exposed to radiation or to chemotherapy, or patients who have autoimmune disease. In tall patients with sexual infertility, no decision can be made on clinical ground between true gonadal agenesis and hypogonadotropic hypogonadism. Both of them will have a karyotype of 46XX. Both of them will have a karyotype of 46XX. And a decision only can be made with the assay of follicle-stimulating hormone and luteinizing hormone. In patients with true gonadal agenesis, the follicle-stimulating hormone and luteinizing hormone will be very high. In patients with true gonadal agenesis, the follicle-stimulating hormone and luteinizing hormone will be very high. But in patients with hypogonadotropic hypogonadism, the LH-FSH will be low. The LH-FSH will be low. Yes, I've said that the third group of patients will have abnormal sense of smell, referred to as olfactogenital syndrome or Kalman syndrome. They have normal or above normal height. They have anosmia. They have sexual infertility, and there's absent or scanty sexual hair growth. Yes, so please note that patients with Kalman syndrome or olfactogenital syndrome, they have normal or above normal height. They have anosmia, disorder of smell. They have sexual infertility or absent of or scanty sexual hair. So these are patients who have described about tall patients with persistent juvenile fissures. So the category we are going to talk now, they are about tall patients with secondary sexual characteristics. Tall patients with secondary sexual characteristics. You see them come, they have normal female habitus. So in this type of patients, find out if they have been having changes that are feminizing or masculinizing at puberty. Ask, if the changes occurring at puberty have been feminizing or masculinizing. So this will help you to know where the pathology is. Is it a viridic type of people? Is it the eugonadal, like polycystic disease of the ovary, or Noonan syndrome? Are these changes induced by the prolonged administration of exogenous drugs? You need to find out, because these patients may have some residual vagina, and by giving them steroids, particularly estrogens, they can have a little bleed. So you need to have these questions. Are there feminizing problems or masculinizing problems? Have they taken estrogens before? So it's very important. In patients with normal female habitus, first of all, exclude local abnormalities. I said the people anatomical defect is one of the major causes, major patients that we see in patients with primary amenorrhea. Anatomical defect. So you must exclude some local abnormalities from the genital tract. You must exclude imperforate anus or underdeveloped vagina, or a septum of the vagina, that is giving rise to cryptomenorrhea. And the signs of cryptomenorrhea are typical. These patients may be having cyclical abdominal pain. About the same time they should be having their period, for about 3 to 5 days, and then it disappears, the pain disappears, only to recall in the next menstrual, the time that they should have the menstrual period. And this cyclical abdominal pain occurs about 3 to 5 days and disappears again. This may persist for some time until we have what we call hematocorpus. Hematocorpus, there is blood deposition in the vagina. Then from hematocorpus it becomes hematometra. That hematocorpus extends to the uterus. And then after hematometra, it then goes hematosapiens. The blood spills over to the fallopian tubes to become hematosapiens. And from the hematosapiens, the blood begins to dribble into the abdominal cavity to become hematocele. That's the normal way it develops. So we need to have to exclude that. Has she been having, is there a local abnormality? Is there a septum when you examine the abdomen, if you examine the vagina? Can you feel a septum? Is the hymen perforate? Yes. Is there a bulge in the lower abdomen that shows that there is hematocorpus, hematometra, hematosapiens, or hematocele? Yes. So it's very important that you know. This group of patients that have imperforate hymen or enveloped vagina, should have an intravenous urogram, because about 30% of them may have abnormalities of the renal tract, including solitary kidneys. If it is found that the patient has a blind vagina without any evidence of a uterus, consider the symptoms of testicular feminization syndrome. Again, if it is found that the patient has a blind vagina without any evidence of a uterus, consider the syndrome of testicular feminization. A casual look at the inguinal area will show that the testes can be palpated in the inguinal area or even in the femoral area, while axillary or pubic hair is usually scanty or absent. It is found that the patient has a blind vagina without any evidence of a uterus. Consider the syndrome of testicular feminization. Then the testes may be palpated in the inguinal region or in the femoral area, while axillary hair or pubic hair is usually scanty or absent. The karyotype will give out this diagnosis, and the karyotype will show 46XY. The karyotype will show 46XY. Testes found in the inguinal canal or ovarian fossa. The testes produce male levels of testosterone, but the end organs are resistant to it due to absence of cytosol androgen receptors. If no local If no local genital abnormalities and there are some female secondary sexual characteristics have developed, this may be a physiological delay. This may be a physiological delay. If no local, no vaginal problem, no vaginal atresia, no vaginal septum, no imperforate tremor, and the uterus is present, this is more likely to be a physiological delay, particularly if there are some female secondary sexual characteristics development. In this type of case, it is better to await with some degree of confidence that the onset of spontaneous menstruation may occur. Some may show various changes at puberty. Some may show various changes at puberty. And this will likely be a mild congenital adrenal hyperplasia that has not been detected previously, or a post-pubertal form of adrenal hyperplasia, diagnosed based on normal female karyotype of 46XX. In this type of these two patients, we have increased serum 17-hydroxyprogesterone or 17 osteroids and increased pregnanetriol secretions from the urine. Now, please let us go again. Patients with some may show virilizing changes at puberty. Those of them that show virilizing changes at puberty, two commonest conditions should come into mind: the congenital adrenal hyperplasia and then the post-pubertal form of hyperplasia. Again, the third that we can show, the third example is adrenal tumors. Adrenal tumors. And they can be diagnosed by assaying the female karyotype. The female karyotype will be 46XX, but the steroids, there will be increased serum 17-hydroxyprogesterone, and for the urinary estrus, increased 17 osteroids and pregnanetriol. And how do you distinguish this from adrenal tumor? Is by the ability of the dexamethasone to suppress the level of these hormones. With dexamethasone can suppress the level of hormones in mild congenital adrenal hyperplasia and the post-pubertal form of adrenal hyperplasia, but it will never suppress that of the adrenal tumors, because the tumors in the adrenal, the hormones in the are excessively increased compared to that of congenital adrenal hyperplasia and post-pubertal hyperplasia. Then the true hermaphrodite, which containing both testes and ovaries, they produce virilizing ovarian. They produce virilization. They produce virilizations. And again, there are some virilizing ovarian tumors too that may occur. Virilizing ovarian tumors like luteal ovarian cells. They can't give rise to virilizing tumors. Rarely, a diagnosis of prepubertal polycystic ovaries may present with aching, associating virilization, and primary amenorrhea. In this case, a high LH and high LH-FSH ratio will give off the diagnosis and will be confirmed by laparoscopy. How do we treat these people? How do we treat people? How do we treat these people? The aim of treatment would be to attain the maximum physiological function of which the individual patient is capable. To attain the maximum physiological function of which the individual patient is capable. So this aim may have to be individualized based on the pathology that is presented. So the aim will be to attain maximum physiological function of and this maximum physiological function can be to complete fertility or to the prospect of fertility or attaining sexual maturation. 3, again, the maximum physiological function may be complete fertility, prospect of fertility, or attaining sexual maturation. But in these type of cases, a firm diagnosis is essential to achieve before treatment can be made in all cases. And again, systematic counseling must take place. Systematic counseling or a multi-grade counseling must occur before treatments are taken. Systematic counseling. So we shall take examples each. The first example we're going to take is Turner syndrome and gonadal agenesis. As I've said earlier, Turner syndrome could be 45XO. These are classical Turners or Turner's mosaic. The Turner's mosaic are 45XO/46XS. Or sometimes you can see 45XO/46XY. That's Turner's, because two different cell lines are developing in the same patients. In Turner syndrome, the only treatment for these patients is to achieve sexual maturation with exogenous steroids. Okay, those of them that have no uterus, the only thing you can do is to attain sexual maturation with exogenous steroids. And how do you go about this? An initial dose of 0.01 milligrams of ethinyl estradiol twice daily for 3 weeks in every month. This will cause the primary breast bud development if given for several months, maybe 6 months to 9 months. That may stimulate the primary breast bud development. But ideally, oral contraceptives would have been a cheaper way to treat these people. But the long-term metabolic effects of this regimen renders this undesirable. Instead of using ethinyl estradiol for like 3 weeks, for every 3 weeks every month, if you give oral contraceptives that contain both estrogen and progesterone, this would have been ideal, but has a long-term metabolic effects on these patients. But then after you have used your ethinyl estradiol, then indefinitely you can now begin a large amount of estrogen, like equine estrogen, and an added progestin, for an indefinite time. Patients with XY karyotype or XY mosaicism should have the area of gonadal streak removed to prevent the risk of development of a dysgenetic tumor, either a dysgerminoma or gonadoblastoma. Dysgerminoma or gonadoblastoma. Some Turner's mosaic 46XS/45XO or 46SY/45XO are phenotypically normal and menstruate normally, and some have been known to become pregnant, and some may benefit from in vitro fertilization embryo transfer. Some of these mosaics, Turner's mosaics, are phenotypically normal and menstruate normally, and some have been known to become pregnant, and some may benefit from in vitro fertilization embryo transfer when they present with infertility. Patients with gonadal causes with or without virilism. These are patients with patients with polycystic ovary, congenital adrenal aplasia. Definitive treatment in testicular feminization syndrome in particular. Definitive treatment aims to achieve transformation to a potentially sexual competent adult. Because in this patient with testicular feminization, they are tall, they have breast development, they have scanty axillary or pubic hair, but there is a very small vagina. There's a small vagina, but there is no uterus. There's a small vagina, but there is no uterus. So the aim of treatment is to achieve transformation to a potentially sexually competent adult. And this means that surgical removal of the sources of inappropriate hormone stimulus, the testes in particular, and reconstruction of the external genital structure along female lines must be done. So, in testicular feminization, when you see a case of testicular feminization syndrome, the testes should be removed. The testes should be removed. And then, when the testes is removed, the small vagina can be constructed, can be advanced forward, but most of the time, we can achieve regular sexual intercourse by partner may extend, may increase the length of the vagina, and this patient can have sexual intercourse appropriately. Disorders of hypothalamus and pituitary gland. Disorders of hypothalamus and pituitary gland. And we have said this in this area, we shall be talking about what we do in Froelich syndrome, where there is a delayed puberty. We shall talk about the treatment of Lauren-Levy syndrome, or Lewis-Beard syndrome, and olfactogenous syndrome, olfactogenital syndrome, or Karma syndrome. But these are disorders of the hypothalamus and pituitary. These are the common disorders that we see often. So what do we do in Froelich syndrome? Patients that we said they are obese young ladies with delayed puberty. Usually, in these pituitary dwarfs, what is present is that there's an isolated deficiency in human growth hormone. There is an isolated deficiency in human growth hormone. These patients will undergo spontaneous puberty. You just need to observe them for years, and gradually, even up to about 20 years, they will undergo spontaneous puberty. Those with pan-hypopituitarism, pan-hypopituitarism, or hypogonadotrophic hypogonadism should be treated initially with human growth hormone. Those with pan-hypopituitarism and hypogonadotropic hypogonadism should be treated initially with human growth hormone to make them sexually mature with gonadal steroids. And then treatment with human pituitary or human menopausal gonadotropin to induce ovulation when pregnancy is desired. First, give them human growth hormone to make them sexually mature with gonadal steroids, and then treatment with human pituitary or human menopausal gonadotropins to induce ovulation when pregnancy is desired. I said the category of pathology we see there is Lauren-Levy, Lawrence-Moberg syndrome, olfactogenital syndrome, or Karma syndrome. Pan-hypopituitarism is treated by replacement therapy. Pan-hypopituitarism is treated by replacement therapy. Hypogonadotropic hypogonadism is treated with LH and FSH, and all this will result in sexual development and menstruation. All this will result in sexual development and maturation. Adrenal hyperplasia. Those patients are come with adrenal hyperplasia, plus other endocrine abnormalities. Classical example in this group is the congenital adrenal hyperplasia. And this congenital adrenal hyperplasia is treated with cortisone to reverse the various enzymatic disorders that lead to abnormal production of cortisol. Cortisone will suppress them. And those of them with hypertrophy of the clitoris, then you can do a chloridectomy. Just like the normal circumcision to reduce the level of the clitoris that is causing the embarrassment. Hypothyroidism, hyperprolactinemia should be treated appropriately. Hypothyroidism, hyperprolactinemia should be treated appropriately. In Prolactinoma should be treated with dopamine agonists, such as bromocriptine, pallodel, or lisuride, as this may shrink the tumor. Pituitary surgery can be used for those in whom drug treatment has failed. Pituitary surgery can be used for those in whom drug treatment has failed. And polycystic ovaries are treated with clomiphene citrate or with many of the modern days gonadotrophin releasing hormone agonists or antagonists. With many of these modern days gonadotropin releasing hormone agonists or antagonists. And this may include the buserelins and guserelins. Buserelins and guserelins can be used in the treatment of polycystic ovaries. Those with gynetricia, which I have mentioned earlier, cryptomenoria, imperforate hymen, surgery is the mainstay. Those with cryptomenoria should be treated as soon as diagnosis is made. Imperforate hymen should be treated by making a cruciate incision in the hymen, just an X incision, cruciate incision, widen it a little bit, and this will allow the tardy collection of menses to flow out. When this flows out, then the symptoms, the cyclical pain will disappear, there will be reduction in abdominal collection, and even in the uterine collection or vaginal collection. A transverse septum should be excised under anesthesia. It will give the same fate as imperforate hymen. Once that septum is excised, the menses, the collected menses, will flow out spontaneously. Then just allow it to flow, put a drain there for some time and allow it to flow gently out for over 2-3 days. Where there is vaginal atresia, or vagina is not developed, you can now do a vaginoplasty, a reconstructive vagina in the normal place. You do a reconstructive vagina that is called vaginoplasty. And this can be followed by regular dilation of the vagina using vaginal dilators or passing a small or medium speculum at regular intervals to ensure that there is no further contraction of the vagina, and which can eventually allow for regular sexual intercourse. If the patient does not have a partner, that can use a gradual dilators. Or if there is a regular sexual partner, the patient can do this to assist her to ensure that the vagina does not close back again. Congenital absence of the uterus, vagina, and most of the fallopian tubes, the syndrome called the Mayer-Rokitansky-Costa-Ulcer syndrome, is common in some climes. It's common in the European areas, but we do not have much experience in Nigeria. The surgical reconstruction in this group is now rarely indicated. Surgical reconstruction in this group is rarely indicated. Much better results are achieved with the use of graduated glass dilators. Much better results are achieved with the use of graduated glass dilators, particularly in patients with the Mayer-Rokitansky-Costa-Ulcer syndrome. Surgical reconstruction in this group is not rarely indicated. Delayed menarche, we said, the diagnosis is made only in retrospect. The diagnosis is made only in retrospect. The onset of puberty in this patient is usually very late, and no treatment should be offered, provided there is evidence of secondary sexual characteristics. No evidence should be offered, provided there is evidence of secondary sexual characteristics. Spontaneous resolution will occur, but sometimes not until the age of 20. It's obvious that many of these primary amenorrhea cannot be prevented. It cannot be prevented, but we should be able to have a look at when a child is born, to be meticulous in examining these patients particularly the outflow tract, to find out if the vagina is there, or if there's a septum, all this, or fissures of Turner syndrome, or fissures of Turner syndrome can be assessed at the time of the newborn, for which a diagnosis, suspected diagnosis, can be made, and for which treatment may be offered before the attainment of puberty. In conclusion, abnormalities in the normal progression of factors responsible for sexual differentiation in utero are the commonest causes of primary amenorrhea. With adequate history taking, meticulous physical examination noting height of patients, sexual infantilism, and presence of secondary sexual characters, and suitable investigation, a precise diagnosis can be made. It is possible to treat these patients on rational and physiological principles. All should be able to lead normal, sexually mature lives, but the prospect for fertility may be possible for a minority only. Ovum donation, in vitro fertilization and embryo transfer may be well for those with gonadal agenesis and a normal uterus. Multi-stage counseling are imperative in the management of these patients from the onset. Thank you for listening. My references: